Okay, so we're at time, so we'll get started. Um, First of all, welcome to everyone who is here. We will be recording this for those who want to share this invaluable information later with people. Um, and so thank you all for joining us. Today's conversation is going to focus on how involuntary treatment laws and policies are changing and as how they pertain to substance use. We're hoping that this is the first of many conversations on this incredibly important topic. And particularly, we're going to be looking at what these shifts mean for people who use drugs and how clinicians, researchers, and advocates and community members can better respond. So we'll be spending about 45 minutes in conversation with our panelists and about 15 minutes in Q&A. So if you have those questions, please place them in the chat. You do not need to wait until the end. And today for our panelists, we have Morgan Godwin, who is an internationally recognized expert in drug policy and substance use. She is committed to bridging the gap between science and policy and served on the Oregon Alcohol and Drug Policy Commission, the Measure 110 Oversight and Accountability Council, as well as other state, city, and county committees. She founded the overdose prevention nonprofit BEATS, overdose and provide harm reduction at festivals and events nationwide in partnership with Rhyme Saver Entertainment. She is a researcher at UCLA Drug Checking Los Angeles, focusing on opioids and illicit drug supply, and she has lived experience with substance use and incarceration and is based in Portland, Oregon. We have Kellen Rusinellia, I think I said that right, who is the Director of Public Health at the Drug Policy Alliance. He drives DPA efforts to expand public health approaches to drug use, including increasing access to harm reduction interventions and evidence-based substance use disorder treatment. He supports partner organizations across the country by drafting drug policy reform legislation, developing supportive advocacy materials, and providing technical assistance. Kellen has been fighting the drug policy and criminal legal system reform for over 15 years, with previous positions at Community Legal Aid SoCal, the ACLU of San Diego, and Imperial Counties, and on the National Board of Directors for Students for Sensible Drug Policy. And lastly, we have Dr. John Messenger, who is a practicing primary care physician working in San Francisco Safety Net System. He is currently an attending physician at the San Francisco Free Clinic, providing care for people without insurance, and a voluntary clinical faculty member in the Department of General Internal Medicine at San Francisco General Hospital, where he maintains his own panel for patients. He has a long-standing interest at the intersection of addiction and health policy with a focus on the issue of involuntary commitment for substance use disorders, publishing numerous academic papers on the topic and engaging in several important legislative advocacy efforts in Massachusetts and California. So welcome to our amazing panelists. So as we get started on this, I was hoping that first of all, you could each take a moment and kind of lay out what you're seeing is the most important shift and the general landscape around involuntary care and commitment policy that we're seeing in the nation today. I see Morgan, you're off mute, so I'll make you talk first.
Oh, all right. Well, having been so deeply involved in the Oregon drug decriminalization, I think clearly no, that has been repealed and returned to a sort of hybrid model where it is, you will go to jail unless you enter treatment right now, provide negative UAs, stop using. And so that transition has been, pretty stark in Oregon and also in California with Prop 36 passing, making someone's third drug possession crime like a prison offense, a several years in prison offense, unless they complete mandatory treatment on, the terms and timeline of the state. So those are the two main actual policy changes that have shifted. But beyond that, there's just a change in the discourse that I've noticed, sort of reframing involuntary treatment under slightly more favorable terms in a way that is sort of shifting away from the crux of it, that it is involuntary treatment.
Yeah, and I'm happy to jump in there too. Yeah, I agree with what you said, Morgan. I do think that there's been a large nationwide shift in how we talk about involuntary treatment, but just generally how we talk about services for people who use drugs and people who have mental health issues. And also, I mean, there's always been a sort of conflation of substance use, mental health, homelessness in this country, but I feel like particularly within the last 5 years or so, those issues have really been mushed together. And essentially, we hear a very strong policy rhetoric that homelessness is caused solely, or at least, mainly by untreated substance use or untreated mental health in this country, rather than homelessness being caused by lack of affordable housing, lack of housing supply. Um, and there's a lot of factors that are going into this, but it's really feeding into this overall arching narrative that the solution, therefore, is we must force everybody into treatment, and that is going to solve all of our sort of public, quote unquote, public disorder issues that we are seeing across the country. And to be certain, we do have real issues that need to be addressed. We do have a lack of treatment. We do have lack of services for people that have mental health and substance use needs. And we do have lack of housing, but forcing people into treatment that might not be clinically indicated, and that people are not ready for or want is not going to get us there.
Great. Echo everything that was said by both Morgan and Kellen, and also just add this is, something that I think has become increasingly politically favorable across party lines. And so, although I'm sure many of us have seen the executive order by Donald Trump, kind of, as Kellen mentioned, advocating for institutionalization or involuntary treatment of people experiencing homelessness, conflated with psychiatric illness and substance use disorders. This was also policies that were pushed by former President Biden during his last term, advocating for expansion of kind of mandatory treatment. And I think this really also is paired with a shift away from other evidence-based treatments like harm reduction. That's something that was explicitly mentioned in Donald Trump's executive orders to shift funding away from harm reduction services towards involuntary treatment. So I think, coming from where I currently am in San Francisco, what is thought as like a relatively liberal part of the country, this is a push that's being made heavily here to, more forcibly institutionalize and treat people with substance use disorders and primarily people who are experiencing homelessness.
Yeah, thank you for sharing that. As somebody who worked in North Carolina for 13 years and then have only been in San Francisco for about two, it's really amazed me at how much the city, which historically has been a bastion of sort of harm reduction services, has pushed involuntary care. Kellen, I want to turn to you, and hoping that you can kind of draw a picture for us of when states talk about expanding involuntary treatment, what does that actually mean in practice, and what have you been seeing?
Yeah, so there's a lot here to unpack. So just to start off, there are in 38 states and the District of Columbia, they already have laws on the books where you can be involuntarily committed for the sole diagnosis of substance use disorder. In every state, there's a civil commitment statute for mental health, but in 38 states, primary diagnosis of substance use disorder by itself is enough, with grave disability or a finding of inability to care for oneself can be somebody can be civilly committed under those laws. In the last decade, we've seen majority of states pass laws that are primarily expanding the ability to civilly commit somebody for substance use disorder. And that's a trend that we are still continuing to see play out today. And that includes things like expanding the number of days that somebody can be civilly committed for. It expands the criteria or the definition of grave disability to include new criteria that hasn't been included before. So people who, for example, in California, expanded the definition to include inability to provide medical care for oneself or to seek out medical care. So there are more potential criteria that people could be committed for. And also in California, with the care court, which doesn't apply directly to a primary diagnosis of substance use disorder, but does include people with co-occurring issues. One of the things that we're seeing, and we're concerned about expanding, is the number of people who can initiate a petition to civilly commit somebody. A family member or roommate now in California can make a petition to civilly commit somebody if they believe that they are no longer able to care for themselves due to a mental health issue. Um, so we are seeing this expand in a lot of different ways. A lot of this is being done through state legislatures. Um, and we're also seeing in several states we're seeing movements towards explicitly moving back towards a mass institutionalization model. For example, last year in Utah, there was a proposal to create this 1,300 bed institution where they were going to use this institution to move the homeless people out of Salt Lake City, essentially to live outside the city, and they would be there under civil commitment. That proposal has been shelved for now due to concerns about the cost and how it was going to be built and who was going to pay for it and staff it. But this is part of the larger conversation around shifting back to this institutionalization model rather than focusing on providing permanent supportive housing and other evidence-based solutions that we know actually address homelessness in this country. Also, primarily civil commitment is done or involuntary commitment is done at the state and local level. There's pretty few circumstances where the federal government can actually do it directly. However, the federal government has a pretty substantial role in encouraging the states or discouraging the states from doing involuntary commitment or other forms of institutionalization. And for a while, the DOJ under the federal government had been sort of the leader in making sure that states were complying with, providing community level services for people with substance use disorder. But under this current administration, we have seen a major rollback of that. And as John mentioned, that first came through the executive order, which directed the DOJ to try and pull itself out of any consent decrees that required or that they interpreted as getting in the way of allowing states to do more civil commitment and institutionalization. And also directed various agencies to provide more funding and technical assistance for states to expand involuntary commitment. And then most recently, we saw the Department of Justice issue a legal memo, essentially saying that they no longer believe that Olmstead versus LC, which was a major Supreme Court case, holding that people have the right to community-based services when for mental health and substance use issues. The DOJ essentially said, we don't agree with that anymore. We don't believe that that case ever held that there is a community integration mandate. And therefore we are, no longer, they're sending the signal that they are no longer going to enforce that. And the signal to the states that if you, please go forward and, expand your involuntary commitment systems. This legal memo has no actual legal effect yet, but, we could see that they try to argue this in new or existing cases that are currently being litigated or will be litigated. But I think this signal is very clear that the federal government under this administration has no interest in protecting the rights of people with disabilities, to make sure that they have community services available to them, and is instead setting the signal that they want to see more institutionalization of people with mental health and substance use disorders.
Well, and then if I'm hearing you correctly, like that memo then is also suggesting like, hey, we would rather you involuntary care and put people into involuntary treatment versus providing them the community-based resources that they would need on a general basis. Is that understanding that correctly?
Yeah, I mean, I think that is definitely part of this, especially when it's read in the context of the executive order and all of the other rhetoric that's coming out of the administration. I think it's very clear that they want the focus to be treatment first. That treatment is abstinence based, and that treatment is going to be forced upon you whether you want it or are ready or not.
Yeah.
And-
Morgan, I was wondering if you, oh, sorry, do you have something you want to say first?
Oh, yeah, I was just gonna say, aside from the actual impact on people's lives of these policies and this infringement on civil liberties, it's clever because if the problem that we have in society is a lack of affordable housing, the solution is more housing. But if the problem can be framed as, oh, it's because people are using drugs and they need to be, put in jail, then we can kind of, pretend that that's the solution, even though we know very well that it's not. Is there a legitimate issue with housing and homelessness? Yes. Is there an overdose crisis? Yes. But reaching for involuntary commitment is taking the most extreme and resource intensive option that we don't even have the capacity for in most places. The highest cost per day, cost per intervention, most disruptive to people's lives. It is deprivation of liberty. This is the land of the free. Like, that is reaching for this nuclear and carceral response because it serves other ulterior motives, instead of doing these much smaller, more accessible interventions that we know actually work.
Yeah, and if I could just add to that too, I do think that this is also, wrapped up in this conversation is the Supreme Court decision in Grants Pass, which essentially said it's okay to criminalize people for being homeless. Um, and in the same executive order where they're saying we are encouraging states to implement more involuntary commitment, they're also saying we're no longer going to fund permanent supportive housing and other things that we know actually work to solve these problems. So they're feeding into the problem that they're saying that they are solving. And they're moving us, away from a system that we know works and back towards a system of mass institutionalization that we don't have the funding for, it doesn't work, and is unethical. And I wanted to mention too, I know I've been talking a lot about involuntary commitment or civil commitment because that's kind of what people are talking about in the general conversation, but I also want to point out that, 35 up to 35% of the people who are in substance use disorder treatment are there because they're mandated by the criminal legal system. So that is another system that is forcing people into treatment, which is, creates a whole bunch of incentives in the treatment system, to serve that clientele or to get more of that clientele, which I think is an important part of this conversation, even though a lot of the sort of national conversation right now is on civil commitment.
Yeah. Well, and what I hear both of you reflecting is that the way that these policies are being rolled out, it's making a moral claim about how the country values people who use drugs, people who are unhoused, people who are in need, right? And it's making this very explicit claim that no, we don't value these people and we want to kind of push them into these boxes where we no longer have to see. Where that's actually where, like, Morgan, I'm wondering if you could lay out for us like the impact that you see this being on not just people who use drugs, but who you see as being the people at most risk for being surveilled and reported and detained, and kind of laying out what you see the risks of like overdose or whatever risks you see
Right.
within this.
Yeah. So in the fentanyl era, I just had research came out a few months ago that showed people's, like, the average fentanyl user in major West Coast cities is using a lot of fentanyl, about 120 milligrams of fentanyl a day, which when translated to morphine is just outrageous. So these tolerances are large. Now, we already knew that, right? Fentanyl stronger. But here's what happens. So these tolerances raise very high. Tolerance is protective, right? So in any interruption, any forced period of abstinence or time in jail or detox, that tolerance halves. And because it was so sky high, having it, the risk is just so exacerbated, because even a few days of not using can really dramatically reduce people's tolerance, particularly the respiratory tolerance. And we've known this for a while. I mean, what are the biggest risk factors for overdose? It's people coming out of detox, treatment, jail. And we don't want to talk about that because we want to think of rehab as this like magic button solution, even though the outcomes, the actual data on it is rather poor. It's very hit or miss. And there is this, well accepted risk of overdose. And particularly, so when it comes to people who are not seeking treatment, right? They are not in the right stage of change. It is not this intrinsically motivated thing. It is something being externally imposed on them. I can speak from my own personal experience that, I thought, oh, I'm not going to get this felony. I'm smarter than that. I'll comply with all their terms and conditions when I was put into drug court. But that's not how addiction works. Addiction is continued use despite repeated negative consequences. And I had already been experiencing negative consequences. Heroin addiction on its own, not fun, not a party. And then, years into it, I get arrested and they say, you're going to go to jail if you don't stop using. Well, I ended up in jail. And then once you're in the criminal legal system, it's very hard to get out of it. And I just cycled in and out of jail, which caused me to lose my job, lose my military education benefits, end up living in my car, lose my car, lose my job, in this just like really rapid descent spiral. And I was the majority, like the highest graduation rate for Portland's drug court, which was considered a model in the country, was about 30%. And that was hailed as a success. Look, 30% of these people have found long-term recovery. I'm not sure what happened to them in the years after, but that 30% was at the cost of 70% of us who were jailed and incarcerated and separated from our kids and lost jobs and destabilized, as if those people's recovery or those people's cessation of drug use was more important than our lives. And I'm deeply concerned that especially now in the fentanyl era, the risks are just magnified, and we're increasing these punitive and carceral approaches at the very same time that we are decreasing supportive services and decreasing access to the things that we actually know work. Like methadone works. Methadone saved my life. Nobody offered me that in drug court. And it's just frustrating that we have to debate and have this discourse as if this was some, intractable problem. It's not. We have excellent solutions, particularly as it relates to opioid use. There's medications for that. We just don't want to do the things that actually work because we're not actually, trying to get people better and stabilize them. We're exerting, coercive control over poor people, Black and brown.
Yeah, and I think something you're highlighting there is like it's not trained providers making these treatment decisions. It's a legal system, it's judges, lawyers making these treatment decisions, which arguably is outside of their scope of practice.
Even in inpatient rehab and detox, it's techs with 6 months in recovery who are administering the services. Like, what are we even calling treatment within this system? Like within mandated treatment, it's so just hodgepodge, inconsistent from one place to the next. And often it's just it's not clinicians, it's not evidence-based, it's not, done by a psychologist or a psychiatrist. It's packets and 12-step meetings, and then you just risk people turning off to the concept of recovery if it's imposed on them. If they start to psychologically associate handcuffs with recovery, that psychological association will take so long and be so challenging to undo and extricate. And that's what happened to me. My mugshot ran in the paper, and I just kept using. I ended up with multiple felonies, and I lost all hope for my future. And like, finding recovery is hard. Continuing to do drugs, that's the easy part. You're not going to voluntarily engage in this much more difficult, arduous process unless you have hope for your future and you believe, that it's possible. So, yeah, I just worry that we're pushing some people even further away in the name of trying to help them.
Yeah, it's funny, like I feel like especially like in an AMERSA context, like we have a very like ideally person-centered like concept of treatment, but we could have a whole webinar on like how treatment actually gets defined within these policy systems.
Yeah.
Um,
Maybe if I could jump in really quickly, Kate, just to kind of echo some of the points that Morgan's alluding to, is just like the trauma that's inherent with like
mhm,
enacting some of these treatments. And something that's well documented in Massachusetts, again, where I've done a lot of this work, is just the criminalization of proceedings of involuntary commitment. And so in Massachusetts, when a petition is approved for involuntary commitment, the judge approving the petition can file a warrant to have somebody detained. And so often it will be policemen or law enforcement officials going, finding people in the community, handcuffing them, bringing them to a court.
In front of their employer, in front of their kids.
Yeah. And like being brought in front of a judge, being held in cells with people who are convicted of crimes. And this is again for a civil commitment, a petition that was filed sometimes by family members. And I think one of the tragic things there is oftentimes family members don't even know what they are signing up their loved ones for. And so, when we're talking about these treatments, again, it's like how are we defining treatment? And is like putting somebody in handcuffs and bringing them to a holding cell to go into a treatment program to how does that align with what our goal is if we're saying that this is treatment?
What's waiting for them on the other side when they get out?
yeah. And John, like I know you have done a fair amount of work, like previously even coming to California and Massachusetts, evaluating and looking at these involuntary care systems. I was wondering if you could speak to us about like what is the evidence and outcomes that we actually know related to involuntary care within substance use treatment?
Yeah, of course. Yeah, I'm happy to kind of talk through the evidence. And I wanted to kind of highlight three key points related to evidence for involuntary commitment for substance use disorder. I think first, maybe somewhat ironically, is that there really is a dearth or lack of evidence for involuntary commitment for substance use disorder. And I think especially when you're looking at outcomes that are either like clinically relevant or really important to patients. Second, that and this may point towards the first, is that states that utilize involuntary commitment for substance use disorder, even those that are using it at alarmingly high rates, rarely have consistent monitoring or reporting of involuntary commitment related data. And then finally, the states that have released comprehensive reports on data related to involuntary commitment for substance use disorder sometimes have found poor outcomes, including kind of elevated risk of overdose, as Morgan was alluding to before. And so the largest meta-analysis that I found on this was published by Werb et al. It was in 2016. And this even looked more broadly at compulsory drug treatment. So that includes, what, we're focusing our conversation on civil commitment for substance use disorders, but also included mandated outpatient or residential programming. And they reviewed a total of 430 studies, and only 9 of them met the inclusion criteria for the meta-analysis. And only 2 of the 9 studies found what they referred to as beneficial effects of the intervention. So one of those studies was based on a mandated community-based treatment program, and at a 1-week time point found decreased rates of substance use. And then the second study they point to was for a mandatory 6-month residential treatment program, so maybe a little bit more akin to civil commitment. And the only positive finding from that study was a reduced risk of arrest at 2-year follow-up. The remaining studies that were included in the meta-analysis were either neutral or kind of found negative impacts of compulsory treatment. And I think just a note here too, as I was alluding to before, is that many of the studies included this meta-analysis, and a lot of the early data on involuntary commitment really focused on more criminal legal outcomes. So like quote unquote recidivism or arrest, and sometimes drug relapse or drug use, but very few, if any, really examined outcomes like overdose or outcomes that are important to patients. And so when thinking about like why do we have so little data on these systems, I think again it's pointing towards a lack of monitoring of the outcomes data for states where these laws are applied. So in 2015, Paul Christopher and a larger group published a paper that looked at the nature and utilization of civil commitment for substance use disorders across the United States. And they did this first by kind of looking at the legal landscape and identifying states that had laws allowing for civil commitment for substance use disorder. And at that time, it was a total of 33 states, which, as Kellen mentioned before, is now expanded to upwards of 38 states. And they reached out in those states, reached out to behavioral health or substance use officials and asked them about the nature and utilization of these systems. Of those states, 13 said that they never or only very rarely applied those laws. But among the remaining 20 states that they reached out to, only 7 were actually able to provide utilization data for their civil commitment programs. And another 7 said that they used civil commitment for substance use disorder regularly or frequently, but couldn't provide specific data or even an estimate count of like how many people were being involuntarily committed. And 6 of these officials were like completely unsure of the extent of the use of these laws in their states. So looking at the states where this is used more frequently, a colleague of mine, Leo Beletsky, and his group at the Action Lab at Northeastern University did a FOIA inquiry to kind of try and get data related to involuntary commitment. 5 states ended up replying to that inquiry. That was North Carolina, Florida, Massachusetts, Minnesota, and South Carolina. And the highest utilizers among this were first North Carolina, where they were committing reportedly 16,500 individuals per year. Florida, which committed around 9,400 individuals per year. And then Massachusetts, which was committing around 5,100 individuals per year. Notably, and Kate, you might be able to speak better to this, but in North Carolina, civil commitment for substance use disorder is actually housed under the same laws as that for psychiatric involuntary commitment. So it's somewhat unclear clear to me if this number of like 16,500 people, if this is like explicitly people who were civilly committed for substance use disorder alone, or there is some overlap with those who being like psychiatrically involuntarily committed. But notably, like in Florida and Massachusetts, the systems and laws governing involuntary commitment for substance use disorders and in psychiatric illness are completely separate. And so the estimates in those states are probably pretty accurate in terms of the number of people who are being involuntarily committed for substance use disorder alone. And so, I'll focus the remainder of my time on Massachusetts. As I mentioned, that's where I've done most of my work. And the State Department of Public Health in Massachusetts actually has released several reports on data related to involuntary commitment for substance use disorder that might be worth to review. And I think some caveats I'll make about the system in Massachusetts, just in terms of our ability to generalize it to like the broader United States context, is that as I mentioned, this system of involuntary treatment for substance use disorders in Massachusetts is not only kind of separate from psychiatric involuntary commitment, but it's relatively divorced from like all traditional medical settings. So in Massachusetts, they have standalone facilities that are explicitly used for treatment of people civilly committed for substance use disorder. I think one very notable thing is that some of those facilities in Massachusetts are operated by the Department of Corrections. And this is the only state that does that, where the largest facility in Massachusetts is actually operated alongside one of the state prison facilities. And there's another civil commitment for substance use disorder facility that's operated by a sheriff's department in Western Massachusetts. And so, I think One of the first studies from Massachusetts that I'll point to, again, was by Paul Christopher. It was published in 2018. And here they interviewed individuals who were entering an inpatient opioid withdrawal management program about their past experiences with involuntary commitment for opioid use disorder. So they screened about 300 people. Around 80 of them had had experiences with civil commitment in the past. And what, some of the more concerning findings from the study was that below 20% of patients reported prescription of medications for opioid use disorder during their involuntary treatment stay. So like less than 1 in 5 people. There was also reported like less than 20% of individuals were discharged with a appointment for connection to community-based care following release from involuntary commitment. And then there was a mean time to relapse report in the study of 72 days, but notably about a third of patients released from involuntary commitment reported relapsing the same day of their release. And so I think this study really highlights some concerns about the use of evidence-based care in these settings. And then moving towards the more recent reports that were published by the Massachusetts Department of Public Health, the first major one was published in 2019 and looked at data from 2016, 2017. And they compared people who had been exposed to involuntary treatment, involuntary commitment for substance use disorder, versus those who had accessed any form of voluntary treatment within Massachusetts, within the Department of Public Health system. And it found that there was a 1.4-fold increased risk of fatal overdose for people who had been exposed to involuntary commitment compared to those who had accessed voluntary treatment. The next big report was released relatively recently in 2024, and they adopted a little bit more of a nuanced approach, just because there are some criticisms of the initial report that didn't really control for patient factors. Maybe the people who were being involuntarily committed had a more severe use disorder at baseline. But this newer report actually used a case crossover analysis. So it took people who between 2015 and 2021 had been exposed both to voluntary treatment and involuntary commitment in Massachusetts. And it looked at both at 30 days and 90 days following those treatment episodes, what were the relative rates of like overdose, prescription of medications for opioid use disorder, and other, I think more relevant outcomes. And this found that for following involuntary commitment episodes, there was a statistically significant 1.4-fold increased risk of non-fatal overdose at 30 days that persisted to 90 days to a little bit of a lesser extent, but still about a 30% increased risk of non-fatal overdose at 90 days for those people following involuntary commitment compared to following voluntary treatment. There was also a trend towards significantly higher all-cause mortality, though this didn't really reach statistical significance. And I think as Morgan was mentioning, we have a very plausible explanation for these differences in overdose risk for people in involuntary treatment versus voluntary treatment. It's been well documented in setting of like incarceration, people who are institutionalized losing tolerance to their substance of choice and then relapsing without that tolerance just have a much higher risk of overdose, especially in the fentanyl area. And so I think, just to conclude and kind of reiterate some of the points I've made, there's like a really, big lack of evidence of involuntary commitment. And very few studies that I've identified have really looked at, overdose and patient outcomes, like patient reported outcomes related to involuntary commitment. States are really not consistently tracking or reporting outcomes of their systems of involuntary commitment. I haven't, dug too much into like Florida, North Carolina, but Massachusetts is, one of the more notable states to publish this more comprehensive reports. And then, when this data is published, like in Massachusetts, there's like the suggestion of a possible increased risk of overdose after exposure to involuntary commitment as compared to other voluntary measures. So I think what I draw from all this is like taken together, I think we really need to be careful and exercise more caution when considering the use of these like precious resources we have when we're using them to expand systems with little supporting evidence while leaving like many evidence-based measures unfunded or underfunded.
You're on mute, Morgan.
And I just want to put into context, aside from all of the outcomes that John just mentioned, the trauma the emotional injury of, being kidnapped legally by law enforcement, brought to a place, you look across, it's your mom who reported you. She's crying, you're at this hearing. Then you go to a place for 30, 60, 90 days, it's boring, it's miserable. You get through it because you always do. You're mad the whole time, kind of stewing. And then for 1 in 3 people, you use the day you get out or within 24 hours, which adds this like immense moral injury where it's just, what was it for? Like all of that time and suffering and pain for what? And that really, really sticks with you. And it for myself, it just, why even try again? Why voluntarily, maybe a year later when I was feeling more motivated, why should I even try again? I know it's not gonna work, it didn't work last time. And just like that, again, that just like psychological association with like anything treatment or recovery oriented, and that like hyper punitive response, that trauma response, those things become linked viscerally, is what it feels like.
Yeah, and like as a therapist who has often worked with people on the other side of involuntary care, I think to your point, Morgan, I mean, this is not scientific, this is anecdotal, but like getting somebody to want to engage in treatment again after they've had this kind of experience, like it is not a conversation that's anywhere near being on the table. There's so much other like now healing that has to be done first. Kellen, I think you were going to say something.
No, I mean, I was just going to echo that point, which is, many people who have substance use disorders, it takes multiple engagements
Hmm.
until they're able to, reach their goals on the other side. And if each time they're going through an involuntary commitment, it's reducing the chances that they're going to engage, then we're getting farther from the goal.
Yeah. I want to remind people who are on that we are taking questions. Feel free to put them in the chat. I've also placed some of the resources that people have talked about in the chat as well, if you're looking for some of those studies. But we did get one question from Anthony where are there limits on the duration of involuntary commitment? And at the end of a term, are individuals at risk of reentering more cycles of commitment? And this can be to anyone.
Yeah, I can jump in first on that. So, because civil commitment laws are defined by the states, there's a wide variance in this. It ranges from about 15 days for the initial commitment to up to 1 year in some states. The most common implemented maximum length for the initial commitment is 90 days. But at the end of a commitment, there's always the chance that somebody could be, that commitment could be extended via the legal proceedings. And then, sorry, what was the second part of that question?
Yeah, the second part was at the end of a term, are individuals at basically greater risk of reentering more cycles of commitment?
Yeah, I mean, I would defer to John on this, but my understanding is that it's very similar to sort of the context of the criminal legal system, where, the fact that you are in the system is um, it's a factor that increases your likelihood to re-enter the system.
Mm-hmm.
Yeah, I
Which
don't know
is,
that I haven't seen, sorry, Maureen. I don't know that I've seen specific data on like recurrent like entry into involuntary commitment. I will say I worked on a small study of about 25 individuals who were discharged to involuntary commitment directly from a hospital. And at least a few of those people had, within a year of monitoring that we did, had recurrent involuntary commitment. And then there was one individual from that study who had 6 separate involuntary commitment episodes, like kind of back to back, like within the course of a year from one another. So there's, definitely, it's not, always one and done. Some people, I would say that there's probably some people who have one or, like involuntary commitment, but it's definitely quite common to see people who have recurrent involuntary treatment episodes.
And John, there's a follow-up question that I think you'll be able to answer from Laura, where she understands Massachusetts has a strong peer movement in mental health and that family members collaborate with peers on policy. And she's wondering if this is similar or the same with SUD recovery policy.
I think like just thinking about kind of like peers or family members and their involvement in these systems. I think I alluded to this before, and it's been mentioned, but a lot of times these treatment systems, family members, loved ones, roommates, are cited as people who can file for petitions for involuntary commitment. And I've encountered numerous people who have been involuntary committed by family members. It's actually the most common person to petition for involuntary commitment in Massachusetts. And as I mentioned, unfortunately, a lot of times people just don't understand like what exactly they're subjecting their family member to. Um, they are kind of in a desperate place where their loved one is in a really, really difficult cycle of addiction. And this is offered to them as like the de facto way that they can intervene on behalf of their loved one. But I've talked to a handful of people who, you know, after experiencing that, after seeing their family member go through that, really regret the decision to involuntarily commit their loved one, having not had the context beforehand. And so, I have seen some of those family members speak out, and I have worked with family members on advocacy efforts to reform involuntary commitment in Massachusetts. Um, and so there is definitely activism amongst like peers and family members, at least from what I've seen. But I think that I have that experience more on an anecdotal basis, and don't know broadly like the wider landscape on like how family members and peers are really working to address these systems.
I know in Oregon, with the Measure 110 cannabis tax revenue, we very heavily funded peers, and there are some very innovative family-oriented programs that sort of, look at the whole unit, not just necessarily the person using substances. But I wanted to just back up a bit and recognize that like this whole, what we're talking about here, involuntary commitment, which is in limited circumstances, in my opinion, needed for some people sometimes, right? My best friend in the whole world in high school developed schizophrenia and needed help. But when we start to blur these issues of substance use and like severe mental health disorders, it is basing any solution off of that on the fallacy, because saying people who have a substance use disorder are worthy or deserve to be civilly committed, right? Deprived of their liberty and institutionalized for 90 days. I think there's an assumption built in there that people with substance use disorders are like completely out of their mind. They're all, screaming naked on the street corner, living in a tent. Like these just like very extreme on this, as far as the spectrum of substance use disorder goes. I think people have an image of people being on one extreme of that spectrum because the only people they see using drugs are the people who have no capacity to hide it, because they don't have a closed door to use behind. And there's just this broad notion that like the vast majority of people addicted to drugs are homeless. And again, we're weaving up problems, right? We have the housing crisis, and that is separate from our substance use crisis, but that intermingling means the solution isn't more affordable housing, it's whatever else. But it just frustrates me because actually like most people with fentanyl use disorder, with methamphetamine use disorder, are housed. At least in most major cities where I can get data access. It's like in Portland, it's 70% of people who died from a fentanyl overdose in 2023 were alone in their homes, their apartments, or their houses.
Mhm.
And I just think the conversation around involuntary commitment blurs the line. People are using these caricatured images of what a person with a substance use disorder is instead of, their colleague Greg, because Greg can't confide in you that he uses substances because, a rash of consequences would befall him. And I just want to extricate these, all the things we're blurring. I just really want to pull them apart. And substance use disorder is not this one extreme thing where people are unable to care for themselves or out of their mind. A lot of people might be constrained by their substance use disorder, but they're still, doing the things, holding it together. They are not a menace to society. They are not a danger to themselves, no more than someone, who continues to eat really junky food, even though they have high cholesterol or smoke cigarettes or have unprotected sex is. Um, and so we shouldn't be talking about incarcerating them.
Yeah. We have two follow-up questions that are kind of similar, so I'll throw them out both to y'all. Do you have resources of a positive treatment modality or process? Like, I think the question's getting at, like, is there an alternative pathway that we could have here? And then the related question is, what do y'all believe is the best way to protect people who use and who need help in an evidence-based, empathetic way?
Yeah, I mean, I'm happy to kick it off. I mean, part of the frustrating thing about this conversation is we actually do know what works. We just don't support it and fund it enough. And that includes things like permanent supportive housing, harm reduction modalities like naloxone distribution, community-based outreach teams. Overdose prevention centers, I definitely think are part of this because it provides a space where people can use and get connected to services in an empathic way, rather than forcing them into something that they're not ready for. Um, you know, Medications for opioid use disorder, so expanding methadone and buprenorphine. Contingency management is another treatment modality that we need much more of, particularly for stimulant use disorders. Um, but there's a lot of things that we know work, but generally it's modalities and treatment that is directed by the client and addressing the needs that they want to see addressed, which is essentially the opposite of what involuntary care offers.
Yeah, I think John, you want to say something?
Yeah, I was just going to echo, I think we're kind of at this place where we have lots of voluntary treatment options, many of which are really great and evidence-based. And involuntary treatment is kind of creeping in as this like what has historically, at least since the, like deinstitutionalization back in like the 70s has been a smaller portion of the care that we're providing, but it's, kind of increasingly taking a funding away from these options that really work. And I think then it becomes even more of an issue because like, say like Morgan said, like I do think there are there are rare instances where people really need a dramatic intervention, but then you take away all of the continuum of care and spectrum of care in the community that people can engage with after that treatment. And like, you're basically, putting them into an institution for whatever it be 30, 90 days, and then releasing them into a system that just doesn't have the resources to meet their needs or continue any momentum that they may have, gathered during that time. And so I really think, I think in most cases, we still just don't have sufficient amounts of these voluntary treatment and harm reduction based approaches. And until we can really say that, I think we really need to, we can't be relying on involuntary care because it's just going to exacerbate this problem where people enter this cycle of involuntary care with no follow-up, this event that can be really traumatizing and damaging to them, and then they have no safety net to catch them when they leave. And so I think just expanding, like Kellen's mentioning, expanding the treatments that we know that work, because I think we made a somewhat half-hearted effort to like, hey, look, we like did a little harm reduction, it didn't do anything, so now we're going to swing the pendulum way back to the other end, and I think that's just short-sighted and won't be an effective approach.
Yeah, like I still remember the day, like I was working with somebody who had a history of involuntary treatment, and his response was, I've been saying for years I wanted to go to a residential program, but nobody would take me. They wouldn't take me on methadone, they wouldn't take me on bupe. And then he ends up in this he's like, I've been asking for this. Why did it take this extreme for me to be able to access the thing, right? Which I think also summarizes a flip of this, right? Like the people are asking for treatment, but we aren't offering the kind of treatment that they want. Um, we're up to time. And so I wanted to ask, what is one practical takeaway you want clinicians, researchers, advocates, the people on this call to leave with?
I can start, and I'll just say, I think we're at this point where there's essentially all states have laws that would allow for involuntary commitment, and there's just a difference in terms of which states have really elevated or invested resources in that. And I think my takeaway in all of this is just that we don't have evidence that this is effective. We know that can be very harmful for patients, and we need to do our best to advocate against using really crucial funds to expand these systems that just have not been supported by evidence to date.
Yeah, I agree with that. And I think particularly clinicians have a role to play in the policy process. Your voice is very valuable and is listened to by legislators. So I would encourage you to use your position to advocate for the rights of your clients and for the things that you know that work and against the things that you know are going to be harmful to your clients.
Morgan, you're on mute.
Sorry. I did an internship at the European Union Drugs Agency, which meant that I had to dose methadone in Portugal. And I was doing a research project on opioid agonist treatment across Europe. And it was like walking through, I don't know, into the Twilight Zone, because I was the youngest person at the methadone clinic by far. People were on oxygen, they had canes, white hair. And it was like I was seeing an alternate reality where all my friends didn't die, where they had the political will to do the thing that worked because they knew it worked, full stop. And, and it was so effective in Portugal that they sort of like contained the spread of opioid addiction. It didn't move to the next wave and the next. And I just it is possible. I've seen it. I've seen it. But the United States has lower medications for opioid use disorder. See, that phrase is American. They use opioid agonist treatment so that people cannot capture long-acting naltrexone in those numbers and inflate them. Like even the words we use are so important. The US has lower coverage than, or about the same coverage as the lowest country in the EU. It's like, I don't know, 15, maybe 18 is where we're at right now, I think, somewhere in there. It's like 92. 92% of people with opioid use disorder access methadone in Portugal. In Spain, it's in the 90s. And instead of doing that, which is costs pennies per dose, there's all these very effective delivery models. We're talking about locking people up for 90 days in a system that kind of, sort of, probably, maybe doesn't work and might hurt them. What? Oh. But it was really cool to physically feel, take my methadone from the mobile van because I've missed my flight and got back on the weekend, and oh, there is a way we can do this. It's not intractable. There are solutions that save lives. I want today's drug users to be those white-haired people in 50 years.
Well, y'all, thank you so much for taking the time to give us this information, have this conversation. Like I said, I'm hoping that this is just like the beginning of conversations that we start having around this topic as we're seeing so much more push for involuntary care and treatment among substance use. The webinar is being recorded. It'll be posted later. So if you have people you want to share it with, please do. And yeah, thank you all.
Thank you for having us.
Thank you, everyone.